as I said, I have a background in this area, and that is both that I worked for a home for deaf in Norway, working for it's a specialized home for deaf with additional handicaps. And there we were arguing about the need for an environment where deaf people, deaf with special needs, need to have a language, sign language. Then at Blue Cross Treatment Center in Lesotho, where you saw the need for the treatment center in terms of increasing capacity in the country in the areas of alcohol and drug abuse, but also how limited we were in terms of reaching out by this being a treatment center. And then the complexity in Nepal that I was a part of, and which I'm not going to use a lot of time doing, but leave it up to Kedar Marahatta, who knows the things on the ground. And there, the work was mostly on community-based work, but still seeing the need for the whole picture. And that being a little start of this session, opening up for discussion, I want to start off by giving the word to Kedar Marahatta. As I said, the focal point of mental health programs in WHO in Nepal. And the theme that you have been given was, what do we choose, institutions or task sharing? You might have changed it a bit, that would be okay, but the floor is yours, Kedar Marahatta.
Let me put up my slides. I hope you can see me and hear me well. Okay. Okay, good. Thank you. It's good, great to be here. Good morning, all, for the colleague joining from Norway. As Heidi gave a summary, that I'll be speaking more on institution or task sharing. I just added it. I've added, as you can see, a little around organizing services or reorganizing if you have already organized it. Many times in countries like ours, it's starting fresh, new program, as we do in many cases. So I'm just keeping this organizing a little, reorganizing in cases we already have some. So when we with a lot of accumulating kind of evidences on what constitutes or what determines mental health, I borrowed this graph from Lancet Commission's publications, which basically demonstrates that there are a lot of determinants for mental health, or poor or good mental health for that matter, including from economic, social, cultural, environmental, and a lot of other factors. So what constitutes mental health care is also broadening based on these determinants, from understanding of disease management, disorder management based on a diagnosis, to more and more mental health as a human capital perspective, enhancing life skills, coping skills, or supporting with the social care needs, etc., etc., and also identifying high-risk population or individuals and providing early interventions in order to prevent the development of full-blown diagnosis. So the mental health care constitutes now a little broader than hospital-based diagnosis and management. I just wanted to bring it to the context here. And then this famous WHO pyramid suggesting what is the need and what is the cost versus how the typical service in situations should be organized. While it says that a lot of care can be delivered by self or in community, in the informal setting, or many cases in primary care, but then even at the tip, it still remains the need. I just want to highlight. Oftentimes when we present this, we focus more on a base. In a situation, in context where there are already some facilities for treatment. Probably it's good to focus more on bottom of the pyramid, but in context like Nepal again, when in oftentimes even the tip isn't there, so we also need to focus on the tip in addition to the base of the pyramid. With this, when we consider mental health as broad as beyond health kind of a perspective, then who provides mental health care also broadens automatically from the mental health professional, typically psychiatrist, clinical psychologist, to more and more every other healthcare providers, general healthcare providers, and then communities, teachers, law enforcement agencies. Now lately, even the peers with the disability movement, like nothing about us without us, kind of a very powerful disability rights movement. So the care provider in a team has also broadened according to the definition of expanded mental health care. And for a professional, the hard fact is in last several years, decades, the care has expanded a lot. A lot more people are getting care, but then in terms of population level, the burden of mental disorders remain more or less same. If you see the suicide rates, with the exception of very little decrease in last decade or so, it largely remained more or less similar, despite, let's say, when you compare the prescription of antidepressant or maybe number of CBT a person has or sessions has been delivered. So there is no population level a decrease in the impact or the burden of poor mental health. So with this, our understanding of institutions as a treatment centers to provide medicines or therapy to in the earlier, like a little far away part. This is now more or less there is consensus that in this asylum type setup or longer term treatment facilities are no more the matter of discussion or debate as such. But then it's not only the physical setup. A typical high fenced, highly secured facility away from community to now then it's not only the physical setup, it's the practices there. Currently, though, such setups are less and less prioritized, but the practice remains in different forms. So while the physical setup, the building infrastructure is an issue, but at the same time, the restrictive practices by put upon the persons with mental health conditions or service users by the policies or legal frameworks in terms of regulating care is also an important aspect of institutionalized kind of a concept. And more importantly, and even to the power imbalance of a provider and the receiver is also in some way they're restricting patients' autonomy, rights, decision making. So in some way, it's also reflects the earlier concepts of institutionalized care. But for Nepal, we never had to deal with long stay state-funded asylums. We never had to do that. Most of the specialized care for mental health has been provided by a psychiatry unit of a general hospital. It's a department of psychiatry more often in most of the instances which provide inpatient care, patient care outreach services. And then we do have a long history of attempting to integrate mental health into primary health care, which has been re-emphasized in last decade a little more with probably the appearance of MHCAP from WHO. The similar approach, though has been kind of practiced since long, is now re-emphasized. But then as I also wanted to link, though, although the care is, it looks like a desirable, but then there are soft components of institutionalization that I discussed earlier still exist here in terms of rights of a doctor or therapist, or patronizing practices, or giving less emphasis to the choices of a person. So yeah, I just wanted to bring it here. And then very recently, some are recent, but some are not. But then in the absence of the stronger treatment facility has resulted in the kind of a proxy longer term centers. A lot of those are on alcohol treatment for alcohol and substance use disorders, a rehabilitation center they call it. But then they are typically run by ex-service users who are maybe recovered from the use, but it's mostly motivated for profit. And then how they market is as a package. They say that 3 months package, 6 months package, 1 year package of rehabilitation for those struggling with addictions. So the duration ranges from at least months to years, even in some cases. And they have very, very highly restrictive, even when after they enter into the packages, even the families are not allowed to meet. So, and then the note for telephone is not access, and all that isn't there. And they're highly scheduled routines, like wake up at this time, do this and that. It's actually the similar practice of earlier days institutionalizations is still practiced here. And even worse is they don't follow the treatment methods, and sometimes the withdrawal to some of the substances are fatal. That, as we know, for example, withdrawal to alcohol sometimes can be very, very fatal. But then we are hearing the instances that they're beaten up for having withdrawal symptoms, and have instances of deaths in such centers. On the other hand, then again, then there are private inpatient care centers. There are oftentimes healthcare providers, again, to make some profit out of it. They're privately run. Inpatient care provided healthcare, led by the healthcare provider, but then they are keeping for a longer time. When patient is paying for their stay, and then the motivation is profit, there is a tendency to keep it as long as possible. And then even for the family, they, bothered by a person with mental health conditions, feels relief to be kind of kept away from the family in such centers and paying fees. So these are the another practices that we are seeing these days as a ramification of old age institutionalization. And then very, very, very recently, actually last 5-6 years, rapidly increasing network of social care institutions, because there are poverty everywhere. Many people are homeless. There are people living in the streets because of mental health problems. And then there are social care institutions to provide food and shelter. But now the network expanding so quickly that these have often become a dumping site even for those with mental health problems or with a disability, chronic mental health problems. Families are more and more sending their relatives there in many instances. So these three kind of, I would say, warning signs for us, actually, in the absence of stronger clinical care provision in the country, are growing. And many times the rights of the persons are ignored here, both by the families because of desperation probably, but more by the institutions, authorities, etc. So it's basically the practice is same as institutionalized care, but in different names and different formats exist in country here. So then this brings us back to, then, do we actually need an institution? I started with, you never had to deal with the asylums, but then it exists in different forms. So is it better to have a stronger service care delivery mechanisms? For example, how do we start? Even if we consider WHO's organized service organization pyramid, how do we start fresh? we have an example of in last 10, 12 years working on child mental health service development in the country. When there was we were lucky to have one child psychiatrist. He came back from America, and then he wanted to do something, and then there was nothing. So so we have a very interesting experience of coming together, developing partnership, establishing at least a node, again the center, again the institution. So we think that this is a success, because when we set up an institution, but then the institution is now reaching out, working as a resource center, both for the government, but also for the development partners. And then with a stronger community outreach kind of approach. So does this model kind of challenges what is recommended? Maybe I don't have an answer, but there's more questions here. And then we feel probably we are inclined that we may need similar approaches even for other programs. Suicide is a bigger issue in the country. In the absence of a stronger, again, knowledge-based institution, again, it's hanging just like that. So do we again need a very similar kind of a focused department or institution, even to lead in suicide prevention, or on alcohol and substance use, or mental health of a aging population? These are the questions, and more and more the public health community are inclined that probably we should build the institutional capacity to provide a mentorship, guidance, and also to lead in service planning and organization. So when you talk again about the institutions, oftentimes we focus so much on the physical structure of it and not much on the practices of it. So probably if we consider in a whole, like more in the physical, but also in the softer kind of a practices, probably even the existing institution, there are a lot of room for improvement to de-institutionalize what we call. But at the same time, we don't oppose so much to set up a new structures with a stronger outreach program. So I think it will soften both extremes of the argument here. The very recently, then, the approach that the government and Ministry of Health and in consensus with the public health community that we are taking is we need probably a much more resource centers, much more centers of expertise here in the country, but then in very, very close collaboration with our ministries of health, provincial health authorities and authorities. The aim of the institution is not the old-fashioned long-term residential care, but to support primary care, secondary care, integrated care in a general healthcare setting. So this is actually a very new chart that we are proposing to the ministries for mental health care, but also for other chronic care models. So I think these are the issues that we are facing with. Maybe we have more questions than answers, but thank you for your patient listening. If you have any specific questions, I'll be happy to speak. And just wanted to mention that my opinions are probably not in total alignment with the institution that I work with. So it's mixed with our Nepal context and also my personal experiences. So thank you.
Thank you.
Over to you, Heidi.
Thank you. Thank you so much for a very enlightening presentation. I suggest that we now have if there are any questions, direct questions to Kedar Marahatta, please do come with them now, and then we can do more discussions afterwards. And there sometimes it might be better to wait with them, so it's a bit up to you if you have very concrete questions. And then I suggest just taking a 5-minute break, just so that we don't do 2 hours in a row or in a. So, any questions first?
Hi.
Yes, please. Hi.
I'm sorry. I'll just. I'm Uddhav. I'm also from Nepal, and I just want to ask you ask you a question about the role of mental hospital Logan-Kiel and also the organizations like TPU Nepal, which are working in the mental health field, and how we can see that how they are working in this field and how we can learn and say like what we can do in the future, learning from their learnings. So I didn't see that those organizations that are really working in the field. My family kind of benefited from the mental health hospital Logan-Kiel. So I think that it is kind of missing. So that's my question. Just yeah.
Yeah, thank you, Uddhavji. Thank you, Uddhavji. Interesting questions. So yeah, I consider mental hospital again not as a long-term treatment asylum style treatment facility. It's still working as a department, though it's a government funded dedicated mental health hospital with 40 to 50 beds. They are also reconfiguring their role now with very recently developed community mental health units. So they're more and more they're also providing clinical services, inpatient services, that's all right, but also reaching out as a national resource center, supporting district hospitals, provide mental health care, also running with WHO collaboration and TPO collaboration on national suicide prevention helpline services. So we are in the process of reconfiguring the role a bit, not limiting them to inpatient and outpatient care, but more to outreach, community care, supporting the government, supporting provincial government, even the district hospitals. So in that role, a mental hospital is part and parcel of it. On NGO, TPU Nepal, other NGOs and civil society organizations, they are playing a massive role in Nepal, and they are the ones before the government actually has a mental health dedicated streamline. They are the ones who are providing services in different forms, doing some advocacy work, stigma reductions, awareness building, and the specific one on TPU is just very strong on research. So they have their role, and then in this triangular collaboration, we are also proposing them to again emphasize to support on districts in care delivery. So yeah, thank you.
Thank you so much. Any other questions? Then I think we'll just keep your questions and especially your comments and ideas and thoughts for discussion afterwards. So please start writing them down to get the good discussion afterwards. But by that, we'll go over to just a short break and come back at 10:05. That's Norwegian. That is in 7 minutes for those who are in other places in the world. In Ethiopia, isn't it? Okay.
This meeting is being recorded.
Yes, the break is soon over. So can you? Wonderful. First of all, thank you so much for your very good putting us into context. So the issue, the context was understood, lies with Morten, but he's not going to have to answer about that because he comes from a totally different context, which is a Norwegian context. And the task given to Morten Ørbæk, who is the head of the Department of Children and Adolescent Mental Health at the University of the Oslo University Hospital, is is to look at the Norwegian context, to show us the Norwegian context and the Norwegian discussion, I think he will be presenting. So not trying to relate it, but seeing what, and I like this adapt, not adopt. So looking into other contexts, we can take things that are relevant to our context on the one or the other, or cultural differences. And that is the task given. And home institutions, a health political illusion is the theme of the next session. The floor is yours.
Thank you for the invitation, Heidi. I will share my screen now. Everybody can see it now? Well, when I started at the University of Oslo in 2006, I asked the senior psychiatrist and the psychologist why they are organizing the services in a institutional manner with the hospitalizing model. And they asked me, because we know that is the right thing. And I couldn't go on with that conclusion. And I started to review what the research was saying and challenges that. And we established what I will address later on, the arena flexible treatment model in 2008, and the iteration of that with the home hospital concept in 2014. So from a historical perspective, here in Norway, the inpatient organizing is the somatic model.
And make it into a presentation, Morten, then we can see, just so it's easier to see the
F5. Let's see. Do you see it better now?
Yes,
yeah. Oh, sorry.
Perfect. Thank you.
The historical perspective here in Norway, it's the inpatient to somatic model and the concept of outer and inner structure, with the outer structure giving the better mental health in regards of inner structural profiling. There was a low degree of the interdisciplinary practice, primarily doctors and nurses, and a low degree of different options for the treatment methods. Today, it's probably another challenge with very different approaches and also a fidelity problem, which we address as the eclectic approach. But that is a common concept that I think has to be addressed as maybe a problem more than an opportunity. Also, there was an approach then aiming to finalizing treatment, and we had long treatment periods. Today, the challenge is maybe short term. And low degree of coordinating services. And today we have maybe too many, and the patients and the parents are talking about the diffusion problem with very much logistics in both the judicial aspects and the coordinating of the services that they need. And you had a low degree of psychoeducative approach also for the family and the system around the patient. Today, the view is that the home hospitals is an organization that is compensating for the traditional inpatient offerings, and it's a strategic move from inpatient to outpatient focus. We believe strongly in digital solutions, but as I often say, the time to talk to people is constant. Either you do it in a digital framework or a face-to-face framework. But there are options there is promising, and we are working now on a holographic concept that we can do real-time holograms and with no boundaries geographical. So it's some interesting concept we're working on. And from the health political perspective, it's a strong user-driven reason for change. But we also see that there is a limiting in the size of new hospital building, and the reasoning isn't always that precise, I think, regarding what the real reason of change is. And we have a challenge of the political views on how to organize versus the pragmatic approach and best practice which the clinicians report, and also to the research. There's a strengthening in the community services, shorter treatment periods, and high availability in the services. So one of the hypotheses we challenged when we have organized our services here at the hospital for the last 15 years is that treatment intensity should follow symptom intensity. But our experience is that you can have a schizoaffective state that isn't profiting on inpatient organization, and we have outreach teams that will reduce the symptoms in a better manner than in hospitalizing the patients. So we constantly have to address this hypothesis because there's more to it than the linearity of this. So what does the patients and their family prefer and report back to us? They want the flexibility in intensity. So I think one of the challenges we have in the hospital is that it's a very dichotomical approach, that it's the bed or the home, but we need the flexibility in intensity in where the patient and the family is regarding the symptoms and needs. The availability. In Oslo, we have time for getting treatment at the inpatient up to 4, 5, 6 months, and that is not good regarding the prognosis. They prefer high and specific competence in therapists, and individual adapted treatment plans coordinated with other services. High level of involvement and high level of evaluating the progress in treatment. And I think the coordinating of the services is the most common topic they are addressing, because they are so highly focused on going on with their lives and managing the stress that they're in, that they need someone to facilitate the coordination at very high level. They are also preferring high level of psychoeducation, so they can understand and identify their vulnerabilities in different stages and prevent the more severe symptoms there. And also there's a rising skeptical of the concept of a full home hospital. And they're often saying that my home is my private space. So some of them are raising their voice now in the regards of the more health political turning of the home hospital focus. So the Arena flexible treatment model, which is an iteration of the Bronfenbrenner's ecological model. We established that one in 2008 as integrating both perspective of the ambulatory outreach services on the one side and hospitalizing on the other side. So we had the most intense frame with the beds, but you also are working ambulatory. And that was a turn which was on better terms with the patient and family autonomy. It was least invasive measures. We didn't have to put the patient and the family in the hospital if not needed. And there was a radical lowering need of coercive care, which is a problem with institutionalizing. We got them higher observational validity, and therefore you can make more realistic treatment goals. And the treatment results are better generalized to a natural context when you're working in this manner. And we also have the flexibility in the structure in treatment intensity. And also we managed to address and controlling the risk perception of the therapist, where earlier we had the only option in putting the patient and the parents in the institution. So before we established a flexible model here at Oslo University Hospital, the treatment focus was on the relation with the child. The treatment time was up to 3 years. There was a high number of aggressive outbursts. We had an overall good treatment outcome when in hospital, but when we see in the long-term prognosis, there was poor. And after, and this was the same patient group, that admittance was based more on prognostic evaluation and not the level of crisis. And the treatment focus was also on the alliance with the family, working with the family and the context surrounding the family. The treatment time was reduced to up to 1 year, and today it's around 6 months. There was a radical lower number of aggressive outbursts. Still, the overall good treatment outcome and more promising long-term prognosis. So the general treatment goals for us was to maintain the patient's integrity, validating observations, motivating change by use of narrative perspectives and reinforcing small positive steps, and clearing obstacles with school and care and so on. And we customized the interventions to the patient and the family. There were high level of evaluating results frequently, also with the family and the other services which we were coordinating. And we also, with our presence, could modify ongoing transactions in context between inside the family and inside their natural context. And the generalizing of skills and results was much greater. And also the families then can be motivated to participate in an intense treatment program with high therapists present in multiple areas. So that made them generate hope in things getting better. And in Oslo and still today, and in Norway, we're talking about the bed, and everything we report on into the health government is regarding day or night and using bed. Well, it can be used on some indications when need of rapid stabilization. You have the parents there. When you need further clinical observations in a controlled context, sleep stabilization, testing out different pharma treatment, and training basic skills in ADL. Also, a principle for us in the systemic approach is that troubled families evade functional networks and functional networks evade troubled families. So therefore you have to work with the context and help them. And troubled families have lower their ability to generalize. And also they have limited transfer of advice to integrated behavior. So you need the facilitation in different contexts. We also working with the school, which is a very important service. We're assisting and adjusting and supervising homeschool and assessing special needs, and we also have temporarily specialized schooling in nearby localities if needed. so you can have a good safe return to homeschool or special school after the treatment. There are some judicial limitations in the home hospital concept, which still is unclear but addressed for several years. Confidentiality is one thing, and the patients talk about when they have digital meetings and stuff like that in their home. There's a limited privacy when parents and others can be in the room or in the home. Also, when you're working outside in the public, there's also have to be discretion around this. There's also judicial limitations regarding coercive use outside hospitals, because the framework today is regulated to inside the institutions. And there are also different legislation between the services, which possibly also can give limitation in the cooperation of the services. So some future insights. I think one issue is that there's a low degree of studies from the field of mental health institutions in hospitals for children and young adults. It's primarily from the child protective services and institutions and from the adult psychiatry. So I think we are moving along with the political views, but we don't have enough studies to facilitate those changes. Is my opinion. I think we have to continue developing models that are based on the principle of the Arena flexible treatment model and have a continuum in the services, not a dichotomy. I think that we need to strengthen the competence in community-based services and coordinating services and adapt them to the needs of the patients. And we need to evaluate the effects in dialogue with patients and family. And we need to train therapists, and not only by giving them new methods, because we know from meta studies that different evidence-based methods in our field there are limited differences. So we need to address more the common factors or the skill sets of the therapists. There has to be a closer dialogue between the services and the politicians, because in my opinion, it's very easy for the politics to say, okay, we go in that direction, because then they have taken responsibility, but that's not the kind of responsibility I am in favor of. We need to address this complex situation in a complex manner. And the field needs economical predictability. Now it's from year to year, which is destabilizing our organization and how we can rig it. And it's very exhausting for both the clinicians, the leaders, and the patients and parents. So that is my thoughts on the topic. Thank you.
Thank you so much, Morten. Really very interesting, and I think we'll give a little opening for questions if someone has specific questions again before we give the word to Ragnhild, who will give her comment. I just want to ask one question myself, and that is, if I had a child who had severe problems, how would it look like for me as a mother to bring my child to your Arena flexible structure?
Well, first you have the referral to the outpatient clinics, and there you do an assessment, and then you do the referral to this more treatment intensity. And the challenge there for many patients right now is it can take a lot of time from the initial referral to the assessment at the outpatient clinic, and it can take up to 3 to 6 months to get a higher intensity. So that's very frustrating, and it's a problem we've seen escalating the last 2 years in the pandemic. So today it's I'm sorry to say that is the situation, and that is very frustrating for especially the parents.
And then there is, if you do get into it, there is a system of both inpatient and outpatient together. Is that how?
Yeah, so it's coordinated in that manner with the treatment team, and that is coordinating also with all the services and the school, and individualizing the treatment plan with the parents and the
So how big are the institutions, the structural institutions?
Well, for children today here in Oslo, it's for the most intensive care, it's for 6 patients simultaneously, and we have a home hospital solution that is for 4 to 5 patients, and we have a day offering for up to 10 persons. So it's not it's not a lot, and we know, and you've seen in the media that number of this number has lowered the last 10 to 15 years radically, and I think there's too much optimism in this problem is solved in home hospital and in outpatient clinics. So we have to address this to the health politicians.
Other questions? No. Then we'll ask Ragnhild. Do present yourself, and I just suddenly realized that I have not actually asked Morten and Kedar to present themselves, which was my plan. So if you chip in a little bit of your CVs while you're talking next time, then that's totally okay. So Ragnhild, do just present yourself, and please your comment to these 2 inputs and to the theme.
Thank you very much. Very good to see you. Thank you for inviting me, and thank you, Heidi, for raising the question and bringing this topic up in a good way. And when I saw the institutions or not institutions, I thought, is that anybody who says yes or no to that question? Does that person exist? And then you said something about not easy questions. And I thought, is there anybody who would think this is an easy question? And I think probably no to both, but maybe that means we don't have the debate enough, or the exploring the different strengths and opportunities enough. We focus a lot on the challenges and barriers naturally because there are so many, but by bringing it up this way and with such good speakers, I thank you very much for making more space for these discussions, Heidi. And thank you very much, Morten and Kedar, for your presentations. They were both excellent and very different. There's very different contexts and resources and available. I am a psychologist by training, but I have worked most of my working life in development cooperation. I'm currently program director at the Norwegian Institute of Public Health for a partnership program between the Norwegian Institute of Public Health and sister organizations in low and middle income countries. I am also an adjunct associate professor of global mental health at University of Bergen, and I have been interested in global mental health, and at least devoted some of my time to this in every job I've had, I think, since I was about 20 years old, which is a long time ago. So I'm glad to be allowed to comment here. I have visited institutions in many countries. As you were talking, I was thinking about what institutions have I seen. I have been to many institutions in Europe during war and after war, and in rich countries and poor countries. I have been to institutions in Latin America, in East Africa, in West Africa, in the Horn of Africa, in Asia, in the US. And I thought, I've seen so many. So an institution is not an institution, neither in structure and building, nor in function. There are so many different ways. And I think both the speakers alluded to that and showed examples of how institutions really have many different functions and structures. And I was glad to hear they're both the constructive and nuanced take, but also the criticism and the dangers with different types of institutions, even those that should be extremely well resourced and where we spend loads of money and really are modernizing, as you said, Morten, in 2022. And there's still a number of challenges, and with so much money going in, and we still can't get it right. It's still, even yesterday, read about desperate family waiting for a whole year. So even if, you know, with all that money, all those resources, so many psychologists and psychiatrists and experts, we still have so many challenges. So I think even if we thought institutions and specialist services would solve everything, it doesn't. We have the evidence from Norway. It doesn't. I am also on the board for SOS Children Villages, and they have had a big process. And I'm glad you used the film in the beginning, Heidi, to show this, you know, also orphanages, because SOS Children's Villages traditionally have been more or less like an orphanage, and they have now decided and are working on restructuring to go away from orphanages and institutions for the same reasons that you were mentioning, but with a lot of challenges as well. I've also worked in institutions in Norway over the years, different types. So I thought there was one issue that didn't really come up that I wanted to bring in, and that is when it comes to the resources we put in, especially with the money, to mental health. In more than 90% of the money for mental health in health budgets go to institutions and specialized psychiatric care. So more than 90% in low and middle income countries go to the specialist services, and in many countries that means one institution, which would be a centralized in the capital institution, or perhaps two. I looked at a few examples. There was often one or two hospitals, meaning that in reality, we're not really shifting the resources towards mental health in primary health care or community-based. Is still being directed to the specialist services and institutions. And often the rationale is, but they will serve as experts, as hubs, as support for the community, which sounds really good. But in reality, I wonder how easy that is, because when we look in again and again, the status for specialists who work with community, with primary health care, with lay workers is not very high. And so getting a sustainable arrangement where those hubs actually help recruit, train, supervise, seems to be difficult. I don't think it's impossible. I think it probably is the way to go, but I think we need to do it somehow differently. And of course, I have ideas for that, but I think we should, you know, take these things into consideration as well. So that was the money matter. And then we had the others that Kedar mentioned, that clinical interventions seem to have limited effect on population level burden on mental disorders, meaning that even if we do it, they don't seem to really take away the burden of it, or the problem. So that's one reason why it won't solve it. I mean, the institutions won't solve the issue alone. And if we have to prioritize, then I think that is one good argument. The other good argument, which you both mentioned, was coercion and breaches of human rights. And there we know that in institutions, the risks of human rights violations increase for all good social, psychological reasons: lack of transparency, big power differences, etc., increased risk of human rights violations. So institutions need to take that as a fact and really work against human rights violations. And Vikram Patel often says that one of the reasons why mental health conditions are so associated with stigma is because of how the institutions are, how we the experts, treat people, that we actually produce or contribute to producing the stigma, and we should take some responsibility for the stigma associated with mental health conditions. I thought both of you had so many good points, and you really gave good examples. I was really glad to see the pyramids being used in practice by Kedar there as a good illustration showing it's complicated, but there is a system to it. I was in well, I'm in Ethiopia at the moment, and I was in Palestine last week, and what it seems to me is that the systems for mental health care very often is the private and the public, and then the NGO sector. And these do not collaborate either. So it's not just the professionals within the system, it's also these parallel systems that compete. And I just saw yesterday on Facebook, somebody suggested a new diagnosis, which was a collaboration disturbance or collaboration problems among professionals. That this was an issue that seemed to cause a lot of harm to patients and their families, that there's lack of coordination and collaboration. And Morten really gave some good examples of that as well. And I think the fact that both of you experts are so critical and so nuanced it's not only speaks to your skills, but I think it's quite typical that people with so much insight are not unnuanced, are not yes or no. And I think that's something that gives hope that we have all this that we can build on. There was a question, do we still need institutions? And we probably do, from what I've learned today. But maybe that question is, as both speakers said, it's different from that. But again, thank you very much for raising the questions. I think these nuances and the critical views on one's own practice and on the whole approach can be really valuable. I wonder if we could do harm, though, for those who are not converted already. When we speak amongst ourselves, the converted who really care about mental health in global perspective, it is important that we have these nuances and criticism. But when we talk to the rest of the world, sometimes I feel that I'm struggling to find that simpler way to communicate, because still very little of any health resource is devoted to mental health. And we have to make sure that we can argue, we can discuss, and we can find solutions, but we should not spend our resources on creating conflicts or looking like we're arguing amongst ourselves, because I don't think we really are, but I'm afraid that sometimes it could seem like that. But what we really want to do is to join forces and try to mobilize more support for mental health at all stages of that pyramid. My final point that I wanted to mention was that we shouldn't romanticize community-based services or at-home hospitals either. People who are in need of psychiatric treatment, of mental health care, where we're considering institutions, are already at risk. And whether they stay at home or not, and part of my study in Niger, many of the children we saw there, they did not get adequate care at home either, even if it could be called community-based. So we shouldn't be careful not to romanticize that either. Thank you very much for all of you.
Thank you, Ragnhild, for good points, and I hope the discussions and the themes are coming up in others, so please do comment. But first, the last comment comes from civil society, so that is Ståle Stavrum from Forut. Please present yourself as well.
Yes, hello. My name is Ståle Stavrum. I'm the International Program Director of FORUT, which is a medium-sized Norwegian development NGO. We have been engaged in mental health work in Nepal since 2015. So we are a newcomer to the field, and I should also say that I am definitely not a psychologist or a psychiatrist, so I do not have that expertise. Just to explain a little bit more about our civil society perspective and our role, the role that we have taken in Nepal in specific. We have there for many, many years been supporting partner organizations that have been working with very marginalized groups, particularly children, children who have been trafficked, who have been traumatized, who have been abused. So that has been their caseload. And caring for these led to the obvious conclusion that if you rescue somebody from a situation, if you intervene in a situation, you need to understand how to go about it. That requires professional knowledge and mental health expertise. And the experience of our partner was that this was completely lacking over the years. And it was sorely felt how to meet these children, how to address them in a way that, first of all, does not create harm, and secondly, does not, actually can give some benefit. How to be sure of that. And our partner made use of visiting psychiatrists and psychologists from other countries that brought in expertise, international expertise, but that was only short term. So basically they felt the growing need over the years for having Nepalese expertise on mental health available in the country. That there needed to be somebody to turn to who really understood, first of all, the context, but secondly, how that context could be translated into the best available knowledge on mental health and mental health treatment. So after the earthquake in 2015, we took part in establishing a child and adolescent mental health unit, an outpatient service, at the National Children's Hospital in the capital. That was our starting point. And we have been expanding that, in a sense, resource center on child and adolescent mental health from that point onwards. Also doing a lot of outreach work, doing capacity building, engaging gradually district health services. And this year we have been able to get a psychologist in one of the district hospitals who is then serving primary health care. So the point is that we're trying to establish something which can serve as a possible model for getting more knowledge out there, getting it out to the wider healthcare system, especially at and finally at local level. Knowing this, we have it's been clear to us that whatever we are doing, we are creating in some sense an institution, some sense a resource center, and some sense something that can support actually the task sharing model that WHO has been advocating for. That is what we've been trying to do. We are civil society too, and we do have expertise in engaging with civil society actors. And especially at local level, civil society actors are ones that can step in and do some genuine benefit. But I think that what we are also very clear about is that our way of intervening is just one model, which we are trying to adapt to the Nepalese context and setting in the best possible way. We have our thinking is also based on very fundamentally on the lack of resources and the understanding that there will be continued lack of resources. That is more or less an almost permanent situation. It will probably only change marginally. So we're trying to get as much bang for the buck in terms of expertise, so that expertise can be used in interplay with the other levels and with the other actors in a task sharing model. This does not. This also means that we have not engaged in or solved the challenges that are inherent in balancing the private public NGO triad. We have not solved that. I think we are feeling our way, and it's probably beyond us to do that. But what we very much want to do then is to go according to the model that WHO in Nepal is now in favor of, is that we are engaging with the government system, we are engaging with the Ministry of Health, we are engaging with the health services, and we are engaging actually also with civil society organizations. But we really want the Ministry of Health's capacity to be raised, and the Ministry of Health's priorities to go up there. And I think that the dilemmas that have been expressed by the presentators today are showing a lot of difficulties that we do not have the complete answer to. First of all, I agree that we should not romanticize at-home treatment. We should not romanticize community healthcare, but of course, we should not devalue it either, because I think that given the financial situation of a resource-poor country, it's going to have to be part of the solution. It is true that mistakes are possible to make at every level. I think that is one of the lessons we have learned. In resource-rich settings, a lot of resources can still be used in a way which violates human rights and which does not support treatment outcomes. So there are always, at every point, so many chances of doing this wrong. And what we are trying to hold on to then is that the level of research, well, the body of research internationally is gradually growing. There is going to be more research on how to engage at community level. And we think that it has to be the professional side who will be the ones who translate research findings internationally into something that can be used at community level and in the nation. And preferably, such translation needs to be context specific enough to address the specific situation in each individual country, because one country is not identical to the next. So I think I'll to answer the question initially, yes, I think we do need institutions, but an institution is not just an institution. It can be many different things. So the idea of institutions is what are the contents and how does it operate, and what role does it play in relation to all the other actors that are out there. So it is this interplay between institutions and actors that is the critical thing. So with those comments, Thank you.
Thank you so much, Ståle, both for your openness about the issues and also your clear ideas and thoughts of what's needed. Yeah. So with that, please, the floor is open now for comments and discussion, maybe disagreements. And that's allowed, even though that's a good thing. If you're working on complexity, you could just say that everything's okay. So we don't need to disagree because we're okay. We need everything because we believe in complexity. But please do, the issues have been said, and so anyone who wants to take the word first? Or ask questions for those of you who have been listening in, or to each other. Yes, Turkistan.
Hi, thank you for a very interesting, well, several very interesting presentations and also comments. I'm wondering.
Present yourself, Turkistan.
Oh, I'm sorry. I'm Tor Christian Birkeland. I'm the executive director of Himal Partner, and we're working mainly in Nepal, but also in the Tibetan region of China. I was wondering if there's a if this discussion about institution versus no institution or less institutionalized approach, if there's a correlation between that and medication, because nobody has said much about the role of medication in this, and typically the NGO community would focus a lot on like group approaches and community approaches, and less on medication. So I'm wondering where medication and treatment fits in this picture.
It's smart to have the mute and the microphone on. Let's take Morten first, and then Ragnhild afterwards.
That's a very interesting question. I think regarding my point on risk assessment of the therapist in charge, my experience in hospital is when the patient is put in the institution, we try to lower the need of pharma treatment and use other structure. So my concern is that in the outpatient clinics, you manage risk with the level of medication when you don't have the other structure facilitating the patient's needs. So that is a very central question.
Yeah, well, that was a very good point. Sort of the opposite of what many people imagine, because you think that you get more medication when you're in an institution, but in fact you often have need for less. Although I've seen the opposite in the sense that when institutions, building back better after disasters, etc., and they try to create better institutions with less physical force, fewer chains, no cages, the coercion actually becomes over medication instead. So maybe we're not using chains, but you're actually using medication to keep people still. So the risk is definitely there in institutions as well. I just wanted to respond one more thing to the medication question, and that is the importance of integrating mental health into primary health care, so that the general practitioner or the nurse or the person who meets patients in the community at the health center can detect and treat and mental health disorders to as large extent as possible, and that will often also involve some medication. And then so these quite simple procedures for trying to understand and to use medication in the community center or in the community by the primary health services is a very important thing, I think. But perhaps with supervision from the institution and the specialized care. Thank you.
Thank you. Any other comments or questions? I think one of the areas that started me off on this theme is it's as I was explaining it's been a long issue, both consciously and not consciously, but I think one of the challenges is when, and that bringing back to Ragnhild's question, where should we will we do harm when speaking to the not converted? Is it easier to say there's one rule and the rule is deinstitutionalization? And I think that's maybe been the strategy of WHO, especially that it is a very challenging question, and therefore you need the discussion, and there isn't that discussion it's difficult to have that discussion. And there was no doubt for many years until very recently, it's been a thought, especially in developing countries where the groups have been few and there have been mostly specialized groups like especially psychiatrists, but also some psychologists, where it's been easy to be thinking mental health institution or mental health hospital as the answer to a mental health problem. It's an easy way to just tick off on that list. But on the other hand, I think what is happening now with this shift is because funding goes to where the recommendations lie. So it means that it takes away the empowerment or the responsibility of the local unit, being local resource people with, of course, the local government or the national government, to do that assessment. And that is maybe where I've been seeing that we come with these easy answers. And I think therefore this not daring to talk about this to the non-converted and to those who actually don't have the expertise makes us give easy answers to something which is more complex, rather than finding what I think both Ståle but also especially Morten was talking about, these more. We have to tweak and find. I like tweak. I learned that from Kedar actually. He uses that word. To tweak and find the solutions that are more specific to the patient group, while these big answers become big answers that are valid, important, but we need the discussions. And where do we get those discussions? Morten.
Well, I think one of my responsibilities in my role here at the Oslo University Hospital is to take the risk of confronting good initiatives from a good value point, but saying it's generic and duplicated services. And I think that we meet parents and patients that have been in the systems for 5, 6, 7, 8 years, and they have experienced goodwill but very contradictory consulting. So from a value point, every good initiative has its existence, but from a cost-benefit point of view, we have to address the generic approach and highly specialized in what we believe in and what the research says, and go on with that. And I think our society is a bit in the political correctness that we applaud the generic models instead of making a statement in what we think will make a change. I think that is a problem in Norway, that we don't take that discussion. And I think that also is probably reflected in the public opinion in other countries also.
Thank you. Kedar?
Yeah, on touching a little on task grading and medications. It's a very important question, particularly in our setting where the disease presentation is so late because of so many other factors. that medication comes at the forefront for two reasons. One is presentation is late. Another one is we do not have enough human resources to be able to provide longer term care. Often outpatients are crowded, therapists have to finish so many patients, and also the care delivery is oriented so much on prescription orientation. Like patient comes, ask, try to make a diagnosis, prescribe a pill and go and send home. So there are a lot of factors for that. And then now I just want to link with the task sharing. Talk a lot about task sharing and MSCAP and all that. We've done some work towards that. The problem is, again, lack of, let me call it the institution still here, just to make it very sound crude. Institution at districts or even at the provincial level, there is nobody to get hold of these primary care providers. So what happens is oftentimes heavily medical oriented primary care providers receiving relatively short training and without support of an expert. There is a risk for medicalizing small mental health stresses and problems here. So that's how I'm coming. It's very complex interplay. We talk a lot about task sharing. For talking, it's okay, but in terms of service provision with a little competency, that's like 5 days training on mental health and 5-7 days. It's impossible to me actually, without strong handholding by specializing persons. And in that absence, as you don't have any structures, actually, the software terminology I'm working, any structures in district hospitals, nobody in even the provincial level to be able to do that. So that has become a major bottleneck in last 4 or 5 years. Even to sustain the task sharing, we need a structure in between, an institution and a smaller scale in between. So that's how we are trying to refocus the support a little towards district hospital level with a catchment of 200,000-300,000 population to strengthen specialized care there, so that the hope that then the task sharing sustains, then the primary care provider feels supported, and then he has somebody to ask to before he prescribes a benzodiazepines, for example. So it's very complex when it actually plays out in the field, particularly a very, very low resource setting like ours here. So I just wanted to mention the dynamics.
Morten?
I also think that we have a big responsibility in controlling the information flow, because I've talked with a lot of non-hospital organizations, Microsoft, etc., that is developing apps for mental health, and where do we make sure that these are the right kind of information? I think in today's society we are threatened by an overflow of information that is giving us a kind of relativism state that can be very confusing for many. And I've talked with patients that have talked to influencers on TikTok and stuff like that, and have a conception of what is needed is very far out from what the highly trained clinicians are assessing. So we need to control the information flow regarding these topics in the public sphere. And I think also we have to see what kind of technological advances and availability is there for kind of democratizing our competence to a broader audience than just the patients in the hospitals.
Thank you. Upal?
Hi, I just want to follow up on the points that Kedar put forward. The things that in our context, we are really focused on, like creating a new hospitals for specific populations, like for the teachers hospital or the civil servants hospital, something like that. And also this health system is totally run by the classic bureaucracy system, like how they define it as a patient as an object. They come here, this number of patients we treated, this number of patients are here, like that, and how many patients they treated. But I had a discussion with health system researchers, and the discussion were like really moving from a new public management, classic bureaucracy system, to new public management, to the new public governance now. How we can involve the general public in the health system and in the health discussion, how to save the health system of the society. So I just wonder how much effort do you have to make, how many more years we have to pass, and how many awareness campaigns or something like that we have to do in order to make people really aware about themselves, to get involved into the health systems themselves, to like ask or like take the control of the health of their society. So I just wanted to follow up on that. It's maybe not a real question, but yeah, that's it.
Thank you so much. Definitely a real question, and I think a difficult one to answer. And I think maybe the answer is no, but we will never actually get there. But Ragnhild, you have others to comment more properly than I just did. Ragnhild, and I see that
I had a question. I just have one. I was going to direct it to Kedar, but maybe somebody else wants to answer. How do we get mental health experts and professionals to engage more and work in community-based settings and support primary health care in resource poor settings? How do we get to be done over time? What does it take? Why is there, status, the money, is it interest? What do we do? They want to be in institutions, they want to be in clinics, they want to be in the capitals, they want to be where there's more money, where there's better health providers, higher status, and eventually they move on to private clinics for people with better income as well. How do we change this?
Kedar,
If I may, it's very difficult.
please
Very
do.
difficult questions to both. The one that's raised earlier and this one. I'll pick the later one. That has been a struggle actually for us to do so. And then even the bottleneck here is also the availability. Oftentimes, at least in the provincial level, there are one or two of those that are waste, if they're lucky. Even in the bigger size health facility, actually, talking to. So many times they're overloaded with the clinical work, and then getting them out is a challenge. One, two is they are they feel that they are underpaid, and then our private system is the system is like a healthcare system is also private, where they earn money. So the morning and evenings are for money, like private care, private practice. So it's hugely challenging. But what has worked in Nepal, actually, not in mental health, but in general healthcare, is mixture of, let's say, government is increasing allowance for the rural practice. One, two is they get some scholarship points for higher education and all that if they practice in rural. Third is also mandating them compulsorily to go for a rural rotation. So that's how they could send at least one doctor in at least in PHC setting in last several years. So I think it's a mixture of so many other things, and of course some of them are like motivated on their own and wanting to do that. So probably exposure early on during their training on such and such, in orienting them could probably help. generate what we call intrinsic in their kind of motivation. They will be happy doing a rural practice. So it's a mixture of many different measures. And the recent one, that the last slide that I showed, is again the government is trying to mandate one medical school to provide support to one district at least. We have fairly handful of medical schools now, 2022. So if one medical school takes care of one district at least to support, in again is task sharing, like mentoring, and then referral and all that, then 22 districts of 77 Nepalese districts will be supported. So so yeah, there are a lot of kind of regulatory actions, but at the same time kind of promotive actions that at least I could say from my experience here. Thank you.
Thank you. We have a question in the chat from Sarah. Hello, I'm a mental health nurse and new lecturer at Northumbria. Yeah, there you are, Sarah. Do you want to pose it yourself? It's just as well that you ask it yourself. Please do.
Yeah. Okay. Hello everyone. My name's Sarah Bisp. So yeah, I've come out of practice about a year ago to come into academia, and what I really noticed in my previous role was this working with very complex cases with children and young people in the community. When we would be reaching crisis point, we'd be exhausting all the community interventions that we could do. There would often be a lot of pressure from social care and also like from families and other professionals to admit young people to hospital, when it wasn't necessarily a mental health need driving that. It would potentially be more of a social care issue. So we end up with a real source of tension, quite a lot of difficulty between professions of, no, you need to admit this person, but it's not really a mental health issue. And then if we do end up with the young person in hospital, then it can be very, very difficult to discharge them again, because there's perhaps of housing issues, or they haven't got somewhere to, they haven't got somewhere to go, they haven't got the right other bits of the puzzle in place to support them. And I've wondered for a while what people's understanding is of what care can actually be provided in a hospital setting, and what, if it's a bit of a myth of this magical thing is going to happen and they're going to suddenly be much better and all the risks are gone. But that's not necessarily the case. It's something else. There's something else that's required. And I think, and I needed to do the literature search on it. What do people expect? What do they think is going to happen when someone goes to hospital? And how is that different in different countries, different places?
I don't see a hand, so please do raise a hand. But I can start at least a little reflection on it, and that is, I like the way you posed it. What do they actually think? It's this putting yourself into the perspective of the parent or the patient, because I think we have this thought that everything will be solved just as soon as we're admitted. And I think your point is that it's so much more complex, our life is. And I think a lot of, at least my experience is that's where I kind of lift up civil society organizations, because civil society organizations have, over the years, they aren't specialized. They actually do work on integrated models, and they look at both kind of the work and lift work, because I think work is becoming increasingly, and that's also in the Norwegian public. So the issue of work and but also living conditions, etc. The challenging thing for in developing countries is that you don't have those, someone who takes care of the housing situation, someone who takes care of the work situation. This is all therefore these community-based approaches, where they also, again, civil society are good at thinking holistically, but it can't be an either or. It needs to kind of empower the governmental structures, and I think that's I did my master's on actually how WHO was perceived in Nepal, and what we saw, and which kind of is a bit of what we've been discussing here as well, is that to some extent due to, or there are different factors, but it accumulated into the earthquake, after the earthquake, where this cluster system meant that WHO together with the government together with WHO, I think is the right way of saying it, got the actors together, both in government, and so that means that they got this discussion. And for those of you who are Norwegian, the word samhandling is actually a very specific Norwegian word, which is not coordinating the different actors to go different places, and not collaboration only, but it's working together, getting the information, understanding that I'm here and you're there, and getting those discussions. And that meant that what I saw was that the discussions in Nepal were quite advanced. So the way you discuss things like an issue, we didn't discuss institutionalization, that didn't come up, but those kind of discussions were advanced. They were the way that we're now talking about it, so that you can actually find the good solutions to those detailed, more complex issues. So again, like an issue like you're posing, Sarah. Yeah, sorry, that was a long. Ragnhild?
Thank you. Yes, well, there was a much better response from Heidi than I had, but since I had it, I will say it anyway. There were 2 points to Sarah's really good question. One was, it struck me that I tend to think people will be negative, they will be scared of institutions, but of course, many people may have different thinking, this will solve our problems. So that's really interesting. I don't know the literature on perceptions on that either, even though there's related fields I do know. And the second was that it's good that you raised the issue of social economic factors, because it's really becoming more and more evident that social and economic determinants of mental health are really important. And in addition, it's social and economic factors in life, such as this can actually force people to send their children to an orphanage, as Heidi's film started off saying, and really important that we keep this up at all times. And I think for my own profession, psychologist, we're really not have been good enough for this field at all, and we really need to pull ourselves together.
Morten?
Yeah, I think regarding Sarah's question, the one thing we address very early is how the parents can manage the grief, because we as therapists, we often think when you're with us, we're gonna fix it. But to be realistic in the initial phase, because then you can see the small steps and reinforcing the progress. When they think that this will be treated very fast, you're going in for failure. So I think it's a big responsibility for the therapist to be realistic and manage the grief in the first conversation, and then put step on step. So and I think that is a challenge for many of the therapists who work with patients because they believe they can make a difference, but they also have to be realistic in their assessments.
Thank you. Listening to you now, there's one issue that has come up for me the past years, and that is that sometimes I feel that when we're working on development aid generally, but also now hearing kind of more and more on the mental health areas that is coming up, we tend to have a very systematic approach to everything. But listening to what you were saying now kind of brings that need to link mental health, and I also believe that means the whole area of development work, to the voices, and the voices come through those who have listened to those voices. And therefore I really believe in having, when we have conferences, to bring in the perspective not only of the beneficiary itself, but also just the clinical perspectives, and having that voice in its systematic way, but listening into to what's actually happening, because it gives new ideas of how you can solve some of these issues that we're talking about. Again, having to lift those up, making them systematically, but getting that flow, I think, is what comes out of good discussions.
Yeah, because final comment on that, because my concern is when the health politicians give expectations that are not realistic, but on what the patient and the families could expect when they come to the hospitals, and the discrepancy between that is very unhealthy for the system and the patients with high stress. So I think we have to close the discrepancy, and we have to talk about that.
Any other, one more issue coming up? And are we now? I had one more myself, and that was the issue of regulation. We very seldom talk about that in development work, but I think one of the things that we know in Norwegian context is that these challenges that you were talking about, Kedar, that you cannot you cannot have institutions in Norwegian context unless they are totally regulated. And I think that doesn't mean that harms aren't there, but at least there's this stress to try to find them. So I think I was kind of posing that this collaboration or some handling and then discussions there, but also that there is a need to kind of dare to even regulate civil society, and that is actually just as an issue, is that in Norwegian setting, Blue Cross and Frelsesarmeen and Societet, all these organizations that have been doing, it's the civil society doing, being funded by the government with big institutions, with a lot of work, etc. But they are regulated. So that's the stress for civil society, but they are regulated. So that stress is sometimes good and sometimes not so good, but that fact that it's always there, it pushes each other to quality and to ensuring new innovation, which civil society more often does. So this thing that Ståle was talking about in terms of private-public, but also NGOs, and lifting up and actually believing that this dynamic is actually what lifts us all. The problem often the civil society would say is that there is this arrogance in the public sector of them being the only ones to see anything. But that's an issue by itself, and that's where civil society then becomes a little bit more like a watchdog and a champion. Yeah, there's Ståle.
Yeah, I just wanted to support that point. I think we all agree that if there's a free-for-all and you have a total open field for all kinds of approaches from civil society organizations, but also from for-profit organizations, you can have a whole new set of human rights violations. So I think, again, as a development practitioner, our fundamental understanding is that human rights violations are there when people do not have any access to any kind of treatment. So that is there. But of course, we don't want to drive into the other ditch either. Regulation, the problem with that is, of course, that it's difficult to formulate, and regulation belongs to, it is the remit of, say, the Ministry of Health. So you need to have people with expertise in the Ministry of Health to formulate that, and they will also be struggling there. So I'm afraid that my conclusion tends to be in dilemmas like this, that you have to muddle through. You have to try it out and balance it through the process of opposing forces and looking carefully at experiences and then modulating and adjusting. I don't have a neater way of doing it.
Thank you, Ståle. Then I think we're going towards an end of this, and I think your yes, muddle through, but also I think actually listening into, and that became very clear in my master's. I've been working in Nepal for 10 years, but I thought I knew the field, and it's a small field, so I thought I knew it. But learning more, even more, through having those interviews and understanding that there is only one real way, and that is actually listening into the country that is there. But I do believe that what we did now is a way of doing it, listening into how have others solved it, what are the other discussions going on, and bringing those discussions home. I do believe we need to do more on that on mental health, and not believe that the answers lie with, sorry, only WHO alone. That is at least an issue from my side. And by that, I'll end with the issue of, let's try to treat the diagnosis that Ragnhild was talking about, that there's a lack of collaboration and coordination. So this is a medicine for that, I hope. So thank you so much. Here there comes a last. We haven't, Helge has been there, and I must admit I'm not totally sure who you are, but you're saying learning from each other. There's a eucoms.net that can be, that we can look into. So thank you so much, Helge. Yes, thank you for joining, all of you, and especially a great thanks to Morten Ørbæk and to Kedar Marahatta for your wonderful presentations, really. And I hope that we can distribute this session to others, and the same with good comments from Ragnhild and Ståle and the rest of you. Thank you so much. Bye-bye.
Thank you.
Thank you.
Thank you.